There we go. Okay, I skipped the introduction. I'll show you this slide, which shows some reasons which I just mentioned, why it is good to think about inherited metabolic disorders and why it's important for your patients to know how to diagnose and treat them. So this is a slide which you shouldn't show, because that's the kind of slide that Emil van Schaftingen yesterday showed, which people like to use to show off how clever they are, because they understand these metabolic pathways. I'd like to relate to you that you don't need to know this. From my point of view, this is what you really should like to know. And that's quite simple. So this is a summary of intermediary metabolism, which is really concerned with the breakdown and changes of nutrients and energy. So we have three groups of metabolites. This is carbohydrates, proteins, and lipids. Carbohydrates, the main carbohydrate is glucose, that's stored as glycogen in the cell. So if you are fasting a little bit, or if you are a few hours after your last meal, you need glucose. You break down glycogen to produce blood sugar. You have galactose and fructose that are special carbohydrates that will be fed into glycolysis. The end of cytosolic glycolysis is a pyruvate. Pyruvate and lactate are the same, they're only a little bit different. And pyruvate is then transported into the mitochondria and changed into chemical energy in the Krebs cycle and the respiratory chain. Proteins have an amino group, so they're usually altered, broken down a little bit in the cytosol. At some stage, the ammonia is cleaved off, then excreted into urea in the urine. When the ammonia group is away, you change an amino acid to an organic acid, and these are transported into the mitochondria and used as energy sources. Lipids, the main lipids are triglycerides for energy. They are stored in the fat tissue. They are released. The free fatty acids are activated with coenzyme A. They're transported into the mitochondria with the carnitine shuttle and then broken down via the beta oxidation and also fed into the Krebs cycle. So this is all you need to know about metabolism. Not quite, but it's a good start. But why is this important? Because we have a few tests that you can use to assess this system. These are the basic tests that should be available in every hospital at any time of the year, even at Christmas night or whenever. That is blood sugar, that is the acid-base status. You do a keto sticks in the urine, and then you measure ammonia and lactate. And that's a very good start to really see, is there something going on in intermediary metabolism? And if you want to know a little bit more, you have some specialized metabolic tests. That's the amino acids in the blood. Usually you can also measure them in the urine. You have the organic acids and the acyl carnitines, organic acids in the urine, acyl carnitines in the dried blood spot. And if you are interested in the lipid metabolism, you measure triglycerides. If you can, you measure free fatty acids. And that's all you need to really know to make a diagnosis in the acute stage. So I would like to go through these groups to give you an idea how do you work on them and how can you actually diagnose them. So if you talk about the inherited disorders in the breakdown of fatty acids, that's relevant when you are fasting, say, 8 to 12 hours. When you need energy, you release the triglycerides, and they're actually converted into ketones because that's done in the liver, and the brain cannot the brain can use ketones as a source of energy. So you have the released fatty acids and they turn into ketones. And if you measure the ketones in the urine and they are too low in a time of catabolism, when the child is sick, when you have high free fatty acids, and you have a hypoglycemia because you have a lack of chemical energy, then you are likely to have a disorder of fatty acid and ketone body metabolism. You can then proceed measure organic acids and acyl carnitines. That's if you're linked to a good center, that goes relatively rapidly, and then you get the diagnosis. So an example for a disorder of fatty acid metabolism is Andreas, who was the first child of non-consanguineous parents in Germany, was premature but developed normally. And the age of 10 months, Andreas was a little bit sick. He had a bronchitis, and then kind of in one day was a little more sick, was reduced to a condition. The mother brought him with acute deterioration, cold sweat, and difficult to link to the child to the hospital. They were a bit challenged. They didn't really know what to do. They measured the temperature was a bit low, the child had arrhythmias, and they didn't even measure blood sugar at the time. So that's a few years ago. But the mother then gave the breast to the boy, and he came around, and then they said, well, this was an allergic reaction maybe, because they gave some medication for the cough. A couple of months later, the mother at around 2 in the morning didn't really had the feeling, maybe I'll look again, and went to the room of Andreas and felt he's not well. He was sweaty, cold, and he couldn't wake him up. She went to hospital again. There they measured the blood sugar, which was low. They had a negative ketosticks, the ketone body in the urine. It can be 1+ if necessary, but it was too low for a child who was obviously in a catabolic state. And the typical acyl carnitine profile then made the diagnosis of the most common fatty acid oxidation disorder, which is MCAT deficiency, which was then confirmed by genetic studies. This is a disease which is very easy to treat, primarily by avoidance of fasting and going into hospital early when you're sick, because you do not need the fatty oxidation to provide energy if you have eaten, really. So after that episode, Andreas had a normal development and no hypoglycemia. But we know from the old studies that a quarter of the children with MCAT deficiency dies in the acute situation if the diagnosis is not known, even if it's very easy to treat. So fortunately, MCAT deficiency is now in most European countries in the newborn screening program, because it's so easy to do. It's one of the conditions which are really amazing, because they can kill you, but you do not really have an invasive treatment. So this is a summary of the fatty acid oxidation disorders. MCAT deficiency is usually diagnosed by newborn screening these days. There are also other long-chain fatty acid oxidation disorders and disorders of the carnitine shuttle, which have a more mitochondrial presentation. I've talked about the biochemical tests, which you can do in a hospital anytime, and the treatment, at least for MCAT deficiency, is pretty simple. So the next group is the carbohydrates, and there are two groups of disorders that one can distinguish. One are the disorders of galactose and fructose. Galactose and fructose are two carbohydrates. They are both activated by phosphorylation, 1-phosphorylation, and this 1-phosphate is highly toxic and causes liver and kidney damage or acute liver and kidney problems. And depending on the age, on the metabolite, and when you first are exposed to it, you have different presentation times. Galactose is milk, is in milk, so you present after birth because you've received milk. Fructose is in sugar and in the normal sugar that you add to meals. So they tend in the middle of the first year of life, usually when the first additional feeds are made. Both with kidney and liver failure can be chronic. The other group are the glycogen storage diseases. So you need glycogen when you have not had food for a few hours. And I would like to introduce you to one relevant glycogen storage disease, that's the type 1. The typical, which it concerns basically the last step in the release of glucose. And the biochemical findings are hypoglycemia, but you have high ketones as opposite to the fatty acid oxidation disorders. You have high ketones and you also have high triglycerides, and you also have lactate because lactate is used to produce sugar. Just to give you an example of a child with glycogen storage disease type 1, typical presentation is a bit earlier than the fatty oxidation disorders with hypoglycemia and associated problems like coma or seizure. And the children have evidence of storage of glycogen, so a large liver, large kidneys, and basically a full face and a full body, really, failure to thrive. When you take blood in the acute phase, it is highly lipemic because the body tries to produce energy by releasing fats, triglycerides. I was called once at 6 in the morning, being told there is a hypoglycemic child and we don't know what it is, and we can't measure anything because the blood is lipemic. It's too much fat in the blood. The laboratory phoned and said, you cannot measure anything, it destroys our instruments. And then you can actually make the diagnosis of glycogen storage disease type 1 in a 5-month-old, hypoglycemia, associated symptoms, and this type of blood is most likely a release problem of glucose. So you don't need to be a specialist, you just need to understand the basic metabolism. There are 2 enzymes that are required. One is the last enzyme and the transporter into the endoplasmatic reticulum. And again, you can treat it. You avoid hypoglycemia, you give frequent meals or slow resorption carbohydrates overnight. And we heard yesterday that in type 1b, where you have neutropenia as an additional problem, you treat the uptake of this toxic compound which is generated in GSD1 by a common anti-diabetic drug. So the last group are the large groups are the amino acidopathies and the related disorders of protein breakdown. So these are substances that are accumulate usually before the amino group of the amino acids that are the components of proteins is released. So they accumulate in the cytosol, and they don't usually have problems with the energy. So they normally do not affect mitochondrial energy metabolism, but cause symptoms through the toxicity of the metabolite. The best known to all of us is PKU, phenylketonuria, where you have a progressive neurological manifestation if you don't treat the affected children after birth. And because it's so good, so successful, you do also newborn screening. Phenylketonuria is basically the non-functioning change from the amino acid phenylalanine to tyrosine, and that interferes with amino acid uptake and other things, amino acid uptake in the brain and other problems. So In the aminoacidopathies, clinical symptoms are due to usually to the toxicity of the specific substrates or specific metabolites that accumulate, caused by the specific enzyme deficiency. Some enzymes are non-pathogenic, so they are non-diseases. You identify through simple amino acid measurement in plasma. Sometimes you have organic acid changes. The other metabolic tests are usually unremarkable, and you quite often get specific treatment which is very successful. The organic acidureas are enzyme deficiencies in this pathway after the amino group has been removed. So they're organic acids that accumulate. They quite often interfere with energy metabolism. I won't go into detail. I will stop soon, and we hear much more about the urea cycle disorders, which affect the detoxification of ammonia. And maybe a last picture of the mitochondrial disorders that have specific changes but are sometimes a challenge to identify, and genetic studies are now basically the best and sometimes fastest way to really get the correct diagnosis. So these are disorders that affect the Krebs cycle and the mitochondrial energy metabolism. So that's my simple summary. The main point is that don't be afraid of inborn errors of metabolism. They are simple, and you can treat them. You can also look at the manifestation of these metabolic diseases, and when you have kind of acute crisis or signs of energy deficiency or sometimes organ dysfunction, you need to think of disorders of intermediary metabolism, and you should know your basic tests. Because if you don't make them, if you don't measure ammonia, you may miss a disease that can be treated. These are other inherited metabolic disorders. There are more than 1,500 now. For many, you need special analysis, but quite often you don't have the same treatment options. So that's not the metabolic tests that you have learned about. When you want to know a little bit more, we have an international classification which is available on the internet, and there's a handbook on the metabolic disorders, which also includes those pathways that I just showed to a degree, which, if you're interested in that, please come to me afterwards. So that's the summary, and the main message is think metabolic pathways and don't be afraid of inherited metabolic diseases. Thank you very much. So, and I think if there are not questions, I'm also the chair of the session. I would, if you can ask questions after the next session, but the main speaker